Thank you very much for the invitation. Today, I'm going to be talking about conductive hearing loss. When we talk about hearing, it's really, for me, quite an amazing organ and an amazing process that happens. The sound waves eventually hit the tympanic membrane that are being transferred to the ossicles, that eventually being transferred through the oval window. When we talk about our talk today, we're specifically going to be focusing on the sound waves that impact the tympanic membrane. This ends up turning the sound waves into mechanical energy, and eventually the mechanical energy is turned into fluid energy. Eventually that fluid energy is turned into electrical energy. So when we talk about conductive hearing loss, we're going to be talking about, if you will, the first half of hearing. Now, when patients are referred for conductive hearing loss, the audiologist already has determined whether this is a conductive or a sensorineural hearing loss. So in the middle here is a classic audiogram of a conductive hearing loss. What they look for is a separation between air conduction and bone conduction. This is what's referred to as the air-bone gap. On the right-hand side is sensorineural hearing loss, and you can see both of these have reduced hearing, but this air-bone gap is what's characteristic of conductive hearing loss. So when the patients come to you and they say conductive hearing loss, the audiogram has already been performed and they have a pretty good sense of what could be causing this hearing loss. So the imaging technique that's most commonly used to evaluate for conductive hearing loss are CT scans. And it's important that you perform your CT scans with the best possible technique. We all now perform multi-detector CT. They can anywhere be from 4 rows to, I just say infinity. I've lost track as the highest number of rows that's available. We perform our studies at 0.625 millimeters thick, and then we reformat routinely the coronal, stenverse, and the postural plane. And I really emphasize to target the reconstructions. This on the top right-hand side is a nice quality study, but when you, the radiologist, should be interpreted, there should be targeted images so we can elegantly see the anatomy, and we'll be discussing various pathologies of this anatomy. So the first step of this talk is that here's our all the anatomy that's involved in a hearing loss. We're just going to initially start off with the external auditory canal. So the external auditory canal forms from the first branchial groove. Just medial to this is a first branchial pouch. So the first branchial groove forms the external auditory canal, and then the first branchial pouch ends up forming the middle ear cavities, and also the cartilage of the first and second arches will form the ossicles, and we'll be discussing this later. But if we have a malformation involving the external auditory canal, this results in the various external auditory canal atresias. So if we have an abnormality that's involving the external auditory canal, and there's still presence of the bone and the soft tissues, this is what's referred to as a bony atresia. And when we look at the image on the right here, this is a classic example of a bony atresia involving the external auditory canal, and it also demonstrates the abnormal anterior descent of the facial nerve. So when we have EAC atresias, also realize that this facial nerve can descend anteriorly, which is what we see here on the CT scan. If there's resorption of the bone, but there's still presence of the membrane, then this is what we refer to as membranous atresia, because there's still preservation of this fibrofatty atresia. And when we look at the coronal images, we can see all this fibrofatty tissue in the external auditory canal. Notice how the bone has been resorbed, but this is a membranous atresia, not a bony atresia. And then finally, if we have incomplete formation of the external auditory canal, then this is what's referred to as stenosis. So here we can see the external auditory canal is formed, but it is stenotic. So these are 3 different types of atresias involving the external auditory canal. When we look at other pathology involving the external auditory canal that could potentially inhibit the sound waves from entering the canal, we can also have things such as bony exostosis. Now, these essentially create a stenosis of the external auditory canal. These bony exostoses are bony overgrowths, and they're typically due to exposure to cold wind and water. They're oftentimes bilateral. They're sometimes referred to as surfer's ear or kayaker's ear. They can result in conductive hearing loss. Because it's stenotic, it's easy to get impaction of earwax and cerumen because the normal egress of the desquamated squamous epithelium becomes inhibited, and they're also prone to otitis externa. They can also be unilateral, and occasionally they're seen with Gardner syndrome. Another pathology that's rare in my experience is Keratosis Obturans. So Keratosis Obturans, as is seen here on your left, is a rare benign lesion that's caused by the buildup of keratin released by the skin lining. Realize that the skin is a highly metabolic organ, and the skin is always turning over the dead skin cells. And the same thing is in the ear. In keratitis obturans, there's a buildup of the desquamation of the skin lining that ends up plugging up the external auditory canal. So when we look at the imaging findings, it's typically a soft tissue mass. In advanced cases, it can enlarge the canal, no frank bone erosion, typically this sort of expansion and regressive remodeling, and it's oftentimes bilateral. So what we've done so far is that we've talked about the external auditory canal. Now let's focus our attention to the tympanic membrane and everything deep to this. So we'll first talk about the tympanic membrane. We'll talk about tympanosclerosis. So on the left-hand side is the normal appearance of the tympanic membrane, and on the right-hand side is what we commonly refer to as tympanosclerosis. On the upper right-hand image is calcification here involving the tympanic membrane. Realize that what we see on the right is actually meringosclerosis. This is hyalinization and calcification of the tympanic membrane. True tympanosclerosis has to involve the tympanic membrane and the adjacent ossicles, as is seen here on the bottom right. So true tympanosclerosis is involvement of the ossicles, where if the calcification only involves the tympanic membrane, then that is referred to as meringosclerosis. The etiology is oftentimes due to chronic otitis media. It can be due to prior pressure equalization tube, and it has been reported in some patients with atherosclerosis. Now, once we cross over the tympanic membrane and we're in the middle ear, realize that fluid in the middle ear can also impact the ability for the ossicles to transfer the sound energy into fluid energy, because the ossicles will not be able to move freely. So middle ear effusions can also cause conductive hearing loss. So if we see, in this case, on the top left-hand side, unilateral serous otitis media, then we have to look at the nasopharynx to see if there's an early nasopharyngeal carcinoma. So understand that the early nasopharyngeal carcinomas arise in the region of the fossa of Rosenmuller. They anteriorly displace the torus tubarius, and this occludes the eustachian tube. When you have occlusion of the eustachian tube, this prevents the normal air pressure from being transmitted from the back of the pharynx into the middle ear cavity. So you develop this middle ear effusion and unilateral serous otitis media. In the case on the top hand right side, we can see bilateral middle ear effusions due to a large aggressive nasopharyngeal carcinoma. Fractures can also cause conductive hearing loss, and the classic fracture that causes a conductive hearing loss is a longitudinal temporal bone fracture. So on the left-hand side, we see the normal appearance of the ossicles, and on the right-hand side, this was a patient that had a longitudinal temporal bone fracture, and they run along the long axis of the temporal bone. So in this particular case, we can see subluxation of the incundomalleolar joint. We can see the malleus is separated from the short process of the incus. The incus is also subluxed. And in this particular case, on this coronal images, we can see that there has been a fracture involved in the tegmen tympani, and now there's herniation of brain context inferiorly, which is resulting in not only incundomalleolar subluxation, but inferior displacement of the ossicles. Other things that can cause a conductive hearing loss, and sometimes this can be subtle to see, and it hasn't been that well described in the literature, but it's hard to see, is ossification of the suspensory ligaments. So when we look at the ossicles involved in the middle ear cavity, they're literally suspended in the middle ear cavity, and they just can't be suspended without some type of infrastructure that supports them. And when we look at this, there are these various ligaments that support the ossicle. So there's a superior malleolar ligament, there's a lateral malleolar ligament, and there's also an incus that attaches the short process to the medial wall. So this was an example of conductive hearing loss due to calcification of the lateral malleolar ligament. This was an example of calcification or ossification involving the anterior malleolar ligament. So it is at least important to keep this in the back of your mind. Again, it's a difficult finding at times to see. But on the other hand, if you look real closely, in patients with isolated conductive hearing loss, you will be able to make this diagnosis. Well, now we'll move our attention right now to the oval window. So the oval window is an oval shaped defect involving the bony vestibule, and this is where the foot plate of the stapes attaches. So the foot plate of the stapes attaches to the oval window right at the scala vestibuli. So when the mechanical energy is transferred to the stapes, it literally bangs on the oval window, and the fluid wave is transferred all the way along the scala vestibuli, communicates with the scala tympani, and you have this back and forth action. This back and forth action transmits these waves to the scala media, and in the scala media is the organ of Corti, and this eventually transfers the electrical energy into the brainstem. So when we look at conductive hearing loss, what we're looking for is some type of abnormality at the oval window that prevents the normal motion of the stapes foot plate and the oval window. And the classic disease that causes this is otosclerosis. So otosclerosis is a unique disease of the otic capsule of unknown etiology. It's characterized by abnormal resorption and deposition of bone in the labyrinth in the middle ear. It's primarily autosol dominant with incomplete penetrance. It's a little bit more common in females than in males, and it's bilateral. And historically, otosclerosis has been an audiologic diagnosis. So when you look at the audiogram, otosclerosis was first initially described by Carhat in 1950 by the presence of this Carhat's notch. So audiologically, what you look for is this little defect right here, right around 2000, and this is the classic otosclerosis on audiology. Now realize Carhat described this in 1950, and this was long before the days of CT and MR. And it's important to understand that this was defined in the 1950s, and you'll see why in a couple of slides. So there's two types of otosclerosis. There's the otosclerosis that involves the window, and this is referred to as fenestral otosclerosis. And fenestral otosclerosis is due to a small area of bone deposition involving the anterior aspect of the oval window in this region, which is called the fistula anafenestrum. So on the right-hand side here, we see this nice little area of deposition right here involving the fistula anafenestrum, and the anterior crucis of the stapes is going right into this deposition anteriorly. As a result, the stapes cannot move normally. In fact, clinic, when the otologists go in there and they want to confirm the diagnosis of otosclerosis, they literally wiggle on the stapes, and the stapes is fixed. That's referred to as stapes fixation. And the reason it's fixed is that this little bone here literally glues the stapes to the oval window. So this is fenestral otosclerosis involving the fistula anafenestrum. Well, the fistula anafenestrum is anteriorly, but there's also this area posteriorly, which is referred to as the fistula anafenestrum. So on the normal image here in the middle, this is the anterior crucis, this is the posterior crucis. The fistula anafenestrum is anteriorly and the fistula is posteriorly. And in this diagram by Schutnik, we can see this small little area of rarefaction of bone involving the fistula anafenestrum. And on the CT scan, we can see a small little area of rarefaction of bone right at the fistula anafenestrum. So again, this is an example of fenestral otosclerosis. Now, the other type of fenestral otosclerosis involves a cochlea, and because this is behind the window, this is what's referred to as retrofenestral otosclerosis. So on CT scan, this is sometimes referred to as cochlear otosclerosis, and we can see the rarefaction of bone surrounding the cochlea. On MR with contrast, occasionally you can see actually enhancement around the cochlea. And I have to admit, when I'm looking at internal auditory canal MRs with contrast, typically I focus on the internal auditory canal to look for vestibular schwannomas, and also we look for cochlear enhancement, etc. But make sure that you look for this pericochlear enhancement, because in patients that undergo MR for sensorineural hearing loss, one of the causes of hearing loss can be this retrofenestral otosclerosis. So make sure that you add this to your checklist. So I mentioned Carhat's notch earlier. This was described in 1950. But as our CT scans have gotten better and thinner, what I've noticed is that I'm starting to see these small focal areas of rarefaction involving the fistula and a fenestrum that do not correlate with the conductive hearing loss. So I went back and looked at the literature years ago, and it turns out that the incidence of otosclerosis is about somewhere around 10%. Gill said about 8.3% in 1944, Weber 11% in 1935, Engstrom 12% in 1940. So the point is that 1 out of every 10 of us have some type of presence of otosclerosis. So what I have been doing more frequently is that if I see this area of rarefaction of bone here right at the classic location of the fistula and the fenestrum, I go ahead and call this early otosclerosis. And it's only these late cases of otosclerosis that I believe have the classic Carhat's notch. Well, the next thing that can cause a reduction that can cause conductive hearing loss is that if you have atresia of the oval window. So we talked about small little abnormalities here involving the oval window with otosclerosis, but if the oval window was never formed, then obviously this can cause conductive hearing loss. So on the right-hand side is the normal appearance of the oval window, and in the middle here is an example of oval window aplasia. We can see that there was never resorption of the bone in the region of the oval window. The next thing that we'll talk about are various ossicular malformations. Now, the ossicular malformations can be a little bit confusing, but what I want to do is try to explain it to you in, I would say, hopefully easy embryological terms. Now, we said earlier that the external auditory canal is formed by the first branchial groove. The middle ear cavity forms from the first branchial pouch. And the ossicles have dual formation. Some is formed from the first arch and some are formed from the second arch. So the way to think of it is the following, is that essentially all of the components of the ossicles in the epitympanum are formed by the first arch. So the head of the malleus and the short process of the incus are formed by the first arch. Now, when we look at the ossicles formed from the second arch, then these arise from the manubrium of the malleus, the long process, the incus, the stapes, head, neck, and the crura, and a portion of the foot plate. So essentially everything in the mesotympanum, the ossicles in the mesotympanum, form from the second arch. So we have dual contributions of the ossicles coming from the different arches. So here's some examples of abnormalities involving the first arch involving the ossicles. So in this case, we can see that the malleus is fused to the lateral wall of the epitympanum. This is sometimes what's referred to as lateralization or fusion of the malleus. In the middle area, it's an unusual case of actually pneumatization of the head of the malleus causing conductive hearing loss. And on the right-hand side, this was obtained from the epitympanum, and we can see that there's fusion of the incus and the malleus. And again, this is a ossicular malformation that caused conductive hearing loss. So when we go more inferiorly, this is a malformation involving the second arch. So here we see an example of the incus that is and we can see it's lateralized, but when we look more inferiorly, we don't really see the long process, the incus. When we look at the epitympanum, here's the head of the malleus and the short process, the incus. Again, when we look at the level of the middle ear cavity, we can see the manubrium of the malleus, but we don't see the long process, the incus. So this was congenital absence involving the long process of the incus. And again, this was due to a focal abnormality involving the second arch, which normally gives rise to the long process of the incus. Another abnormality that we can see that's, again, arising from the second arch is the monopod stapes. So typically the stapes has two crura. There's an anterior and posterior crura, but these are all examples of only one crura of the stapes form. And so in this example on your left, we can see only the posterior aspect of the crura being formed. Another example here, only one crura of the stapes present. And in this coronal image, again, only one crura of the stapes was seen. So these are examples of monopod stapes. And again, if we don't have a normally formed stapes, this will result in a conductive hearing loss. Well, the next thing that can cause conductive hearing loss is a mass involving the middle ear cavity. And the most common masses that will involve the middle ear cavity are cholesteatomas. So there's two types of cholesteatomas. There's a congenital and an acquired cholesteatoma. So a congenital cholesteatoma is an embryonic rest of epithelial tissue without a history of a tympanic perforation. There's no history of middle ear infection, and the imaging findings are a focal mass medial to the ossicles, and they can be indistinguishable from a cholesteatoma. But the key thing here is to understand that the congenital cholesteatoma is not associated with any type of middle ear infections. The next type is the acquired cholesteatoma. So an acquired cholesteatoma has different pathogenesis, but in general, what we most commonly use and what I most commonly use is this invagination theory. So in this particular case, the invagination theory is that we normally have communication between the back of the pharynx and the middle ear cavity. If there's obstruction in that eustachian tube, in that communication, instead of the air pressure coming out, it starts to retract the tympanic membrane. The tympanic membrane has two different components. There's a tense part, which is the pars tensita, and there's a flaccid part, which is the pars flaccida. So if there's negative air pressure, the area of the tympanic membrane that becomes retracted is in the pars flaccida. So this is an example of an attic cholesteatoma. Here we see this cholesteatoma that's located in the classic location where we would see the pars flaccida being retracted superiorly into the epitympanum. And when we look at this coronal images, we can start to see subtle erosion here involving the head of the malleus. So that's a nice example of an attic cholesteatoma. And because the ossicle is now disruptive, this would result in conductive hearing loss. In this particular case, another example of a cholesteatoma. Here we can see the malleus, we can see the manubrium of the malleus, but notice how there is no incus. So the short process of the incus here is absent. Once we get down to the middle ear cavity, we can see the anterior and posterior cruce of the stapes. We could see this soft tissue mass right here that's eroding the long process of the incus, and we can see erosion of the capitulum of the stapes. So again, another example of a pathology of conductive hearing loss due to cholesteatoma. We can also have other causes of abnormalities involving the middle ear cavity. And again, the key thing here is that if we have a mass right here, this is going to impede the normal mechanical transfer of sound energy to fluid energy at the oval window. So this is an example of a middle ear adenoma involving the middle ear cavity. This is an example of a glomus tumor. In this case, this is a glomus jugulotympanicum. So here's a large mass here involving the glomus jugulare, and we can see a focal area of abnormal tumor extending into the middle ear cavity, in fact, abutting the manubrium of the malleus. On the coronal images here, we can see this densely enhancing mass arising from the jugular foramen. We can see the multiple flow voids, and we can see the tumor extending superiorly into the middle ear cavity. We can also have developmental causes. And encephalocele, if we can cause conductive hearing loss, but sometimes we can miss them if we don't look carefully. So on the right-hand side is the normal appearance of the manubrium of the malleus in the epitympanum. And notice the space here between the top of the manubrium and the roof of the middle ear cavity. So this is the tegmen tympani. Notice that normal space. But on the left-hand side here, we can see that the normal superior space in the epitympanum is absent. And the head of this malleus directly abuts the expected location of the tegmen tympani. And in this case, the tegmen tympani is absent, and this head of the malleus is now abutting the inferior temporal lobe. So you can see this temporal lobe is going to prevent this malleus from normally moving. This is the parasagittal images. Again, normally we can see the air between the roof of the manubrium and the tegmen tympani, but here we can see the top of the manubrium of the malleus directly abutting the temporal lobe. And again, this is an example of a subtle encephalocele that can cause conductive hearing loss. And the last thing that we're going to talk about is what I referred to as, in a way, pseudoconductive hearing loss. And you may have read about this in the literature. This was the classic third window of conductive hearing loss. So instead of having the classic air-bone gap, there is a classic audiological appearance to this pseudoconductive hearing loss. So initially there's an air-bone gap at lower frequencies, but at higher frequencies, there is no air-bone gap. And this is what's felt to be due to the third window phenomena. So when we take a look at the third window, the normal appearance is on the left-hand side. So typically, the fluid within the inner ear is contained by bone. So you can see the top of the semicircular canal is covered by bone. The vestibular aqueduct is nice and small. We can see that there is no dehiscence whatsoever involving any of these inner ear structures. But when we actually look at this whole third window concept, we can see various abnormalities that cause and communication between the fluid and extend outside the bone, and extending outside of the bone here is the CSF. So things such as dehiscence of the superior semicircular canal, enlarged vestibular aqueduct, some type of cochlear dehiscence, this can all result in a third window and result in what is sometimes referred to as pseudoconductive hearing loss. So if you do have someone with a conductive hearing loss, realize some audiologists may not actually say pseudoconductive hearing loss, but they just, again, may say conductive hearing loss. We have to be aware of the various pathologies that can result in this type of hearing loss. So even though the history may come in as conductive hearing loss, we still need to evaluate for the presence of superior semicircular canal dehiscence. So here's an example in the in-plane and the orthogonal view of superior semicircular canal dehiscence. Realize that dehiscence of the posterior superior semicircular canal, as is seen here on the axial and the coronal images, there's our posterior superior semicircular canal is also dehiscent. This can result in this conductive or pseudoconductive hearing loss. In this case, we have direct communication between the internal auditory canal and the cochlea. This is the X-linked conductive hearing loss. And this is an example of the large vestibular aqueduct. And notice there's frank communication here between the endolymph and the CSF. And again, this is that third window, that, if you will, internal dehiscence. And again, this can result in that hearing loss as well. So in summary, what I've tried to do over the last 25 to 30 minutes is talk about specifically conductive hearing loss. We talked about various pathologies that can impede the normal transfer of sound waves through the tympanic membrane, causing mechanical energy involving the ossicles, which is eventually transferred to the oval window. So thank you very much for your attention.